Hello and welcome to part 2 of motor disorders. In this second video, we are going to talk about spinal cord injuries, cerebral palsy, and ALS. Remember to watch part 1 to learn about multiple sclerosis, Guillain-Barré, myasthenia gravis, muscular dystrophy, and Parkinson. So let's get started with our blank map. And I think we're going to actually start in this lower corner with cerebral palsy. Cerebral palsy is a permanent, non-progressive motor disorder. Cerebral palsy is due to damage in the motor areas of the brain and is often due to some type of anoxic injury that occurs either during pregnancy, during birth, or immediately after birth. If a baby has experienced an injury that causes cerebral palsy, that motor damage is often not evident for quite some time. High-risk babies include those who are low birth weight, preterm, or babies who are part of multiple fetuses, like maybe triplets or quads or quintuplets. Even twins, but the higher the number of fetuses, the more risk. As the baby approaches age 1 to 2 years, those with cerebral palsy will not be meeting their motor milestones. They will not be sitting, walking, or able to meet other milestones. They may even have persistent infant reflexes. Muscle tone may be increased and even spastic or hypertone. Diagnosis usually comes about 1 to 2 years of age, and that's when they're not meeting their motor milestones and it becomes evident. There is no specific test for cerebral palsy. It is really by physical exam and maybe gathering some information about birth history and pregnancy history. Frequent complications include visual problems, seizures, scoliosis, and that's because of the tight muscles tend to pull the spine to one side or the other. There'll be motor delays, and in some cases, cognitive delays or issues. Now note that not all children with cerebral palsy have intellectual disability or cognitive delays, but that it becomes difficult to assess children's intelligence levels if they're unable to talk or move or respond to some of the test questions. So some will have cognitive intellectual disabilities and others may not. ALS, or amyotrophic lateral sclerosis, is a neurodegenerative disease that affects nerve cells in the brain and the spinal cord. It results in progressive muscle weakness and wasting. Eventually, the motor neurons die. Causes may include genetics and environmental conditions or even exposures. We do see more males affected than females. Manifestations include muscle atrophy, spasticity, loss of sensory function, and eventually respiratory failure. Again, as far as the patho, we see a degeneration and scarring of motor neurons. Prognosis is usually about 5 to 10 years after they've been diagnosed. ALS is commonly referred to as Lou Gehrig's disease. Now let's move up and talk with spinal cord injury, which is our last motor topic. Spinal cord injury is usually the result of a motor vehicle accident, a fall, or a sports injury. It's devastating and costly. We see more males with spinal cord injury due to the cause being trauma or injury related. Now, with the pathophysiology of a spinal cord injury, there is the primary injury, which is the injury to the cord. The cord can be transected, which means it's cut. It can be contused, which means it's bruised, or it can be compressed. Compressed or contused cords may not result in permanent damage, but transected cords do. Although the primary injury is devastating, the secondary injury from swelling, ischemia, from maybe overswelling and lack of blood flow to the area, or even hemorrhage after the initial injury can also cause additional disabilities. It actually may take several days to a week or so to assess the full extent of the injury due to the swelling. In a spinal cord injury, the degree of loss of function corresponds to the level of the spinal cord injury. So that's often referred to by vertebral location, such as a cervical injury, a thoracic injury, or a lumbar injury. And they'll actually name the vertebrae number. So they'll call it a T12 injury, or a C6 injury, or an L2 injury. The higher the injury, the more of the disability that occurs. Often a dermatome map, if you've ever seen one of those, kind of helps identify the functional loss that's associated with the injury. When there's high thoracic or cervical injuries, respiratory function may be compromised. If there's lower injury, then it may just be the lower extremities or a paraplegia that develops. Now, there are several acute and chronic complications of spinal cord injuries, the first of which is spinal shock. Spinal shock is immediate. It's a temporary loss of reflexes or tone below the level of the injury. Spinal shock lasts anywhere from maybe 2 days or a day or two to maybe a month. And during the time of spinal shock, the body is flaccid. There is a loss of muscle tone. And we know that spinal shock is resolved when the muscles become spastic or toned again. In spinal shock, there is a loss of autonomic responses. This loss of autonomic responses is associated with bradycardia, hypotension, and a lot of it's because skeletal muscle tone is lost. And skeletal muscle tone assists with supporting blood pressure control by kind of press the muscles. When your muscles are toned, they kind of support the blood vessels and keep the blood vessel tone up and your blood pressure up. Now, neurogenic shock we see in those who have had a T6 or above injury. And what neurogenic shock is, it's actually disruption of the sympathetic nervous system. Remember that sympathetic nervous system is the fight or flight. So there's a loss of fight or flight. We also know that neurogenic shock is a form of distributive shock. Therefore, the type of symptoms that we see is low blood pressure or hypotension from massive vasodilation. We see bradycardia, and also maybe the inability to sweat, or some loss of thermoregulatory control. Neurogenic shock may last up to 6 weeks. ICU support is usually required for neurogenic shock. Now, autonomic dysreflexia is more of a chronic issue. And it's something you really should be able to recognize. What we have is, even though it's a chronic issue, that means that it can occur anytime to someone with a spinal cord injury, usually a T6 or above. So it could happen right away, maybe within days of their spinal cord injury, or it could happen 20 years after their spinal cord injury. So it's anything, it can happen anytime during their lifetime after they've had a T6 or above injury. And although it's a chronic issue, what we see is it's an acute response or a quick onset response to some type of sympathetic stimulation. And that sympathetic stimulation is usually something like maybe pain, full bowel or bladder. Maybe the patient, because they can't feel their leg is maybe caught in the bed rail and has been injured. Or maybe there's something in the bed that's poking the patient or causing an acute pain response. And because they don't have feeling in that area, they can't tell that it hurts, but the body is still responding to that sympathetic stimulation from the pain. The thing about autonomic dysreflexia is that it needs to be treated right away. What we see is patients will develop a sudden increase in blood pressure, headache, flushing, maybe bradycardia. And so this sudden increase in blood pressure can actually cause stroke or a lot of damage. So it needs to be recognized right away. And what we do is we try to try to find out what the source of the sympathetic stimulation is. And we would also maybe give some medications to lower blood pressure and control pain. Other complications include altered sensory and skeletal function, and this really depends on the location of the injury. We know that individuals that if they have paraplegia or maybe a lower thoracic or lumbar injury, they don't have feeling or movement in their legs. Perhaps some who have a cervical injury may not even have movement or feeling in their arms, legs, or may not even be able to manage their own respirations. So it really just depends. The motor and the sensory below the level of the injury are lost. In some individuals, there may be altered respiratory function. We see this mostly in high-level injuries, maybe cervical injuries, where they're unable to maintain their respirations and they may need ventilatory support. There's often disruption of bowel, bladder, and sexual dysfunction. There's immobility, and issues of immobility can lead to the development of deep vein thrombosis or clots, edema in the lower extremities, altered skin integrity, maybe the development of decubitus ulcers. So just complications of immobility, even pneumonia. And last, altered temperature regulation may occur in some individuals who have spinal cord injuries. And there you go, the completed motor map. If you missed Motor Disorders Part 1, be sure to circle back and watch that video. And if you find our videos helpful, please remember to like and subscribe for more pathophysiology help.